So good afternoon, everyone. Welcome to Neurology Grand Rounds. Claire's listening. Sorry we're not right on time, but we're close. We're close to being on time. So it's a pleasure to have Dr. Franklin here to speak to us about pain management. Dr. Franklin's the medical director of the Washington State Department of Labor and Industry, and he's been a professor at the University of Washington since 1988 in departments of environmental, occupational health services, and neurology. So looking at Dr. Franklin's CV, I was kind of inspired because he's covered a lot of ground in his career and kind of reinvented himself several times in what his big interests are. But his career started out, he got his BS in mathematics at Franklin and Marshall College in Pennsylvania. Then he went to medical school at George Washington University, where he graduated AOA. After doing his medicine internships, he did a neurology residency at UCSF and then a fellowship in neurochemistry at University of Chicago. He's held faculty positions at the University of Texas Health Sciences in Dallas. And in between there, he actually left academics briefly, was in private practice, and did that for many years. And he informed me that seeing the challenges of back pain and things that he wasn't able to help, he kind of redirected himself and got an M.P.H. At Berkeley. Following that, he entered academic positions at the University of Colorado, and then moved to Washington State and his appointment at the University of Washington in 1988. He's a member of numerous professional societies. He's held leadership positions in these, including he was the chairperson of the neuroepidemiology section of the American Academy of Neurology. He's had numerous research grants and awards, and published on a wide range of topics, as I mentioned, from really cellular, molecular things, looking at amino acid transport into CSF, to clinical studies on diabetic neuropathy, Parkinson's disease, and MS, and more recently, issues related to occupational health, which is, I believe, part of the content what he's going to speak to us about today. So, Dr. Franklin, thank you.
Thanks very much for having me. I think this is about the third time I've given a talk like this. I reported the first opioid deaths in the country in a peer-reviewed journal. And these were injured workers who started coming across my desk in about 2002 when we had changed the rules in Washington State, like they did almost everywhere else, to make things more liberalized for using opioids for chronic pain. And this is one of the worst man-made epidemics in modern medical history. And what I hope to talk to you a little bit about today is how this happened, what we've done about it in Washington State, and where we might be heading. Franz Kafka, not many people know, was a workers' compensation adjudicator in Bohemia. And he only wrote 2 books during his lifetime. A Country Doctor was one of those books, and he said, it's easier to write prescriptions than it is to come to an understanding with people. And that's especially true, I think, of people in pain. It's very hard to take the time that you need to take to figure out what people need and in terms of their livelihoods and their functionality and their family life. So it became quite easy to write prescriptions for opioids. Unfortunately, this was the little piece that was quoted over and over again that was one of the reasons that led to the dramatic liberalization of use of opioids. This is a letter, a paragraph in the New England Journal of Medicine, and it was based on a lot of hospitalized patients. People in the hospital get opioids, and they looked to see what % of them became addicted after getting hospitalized opioids, and not many did. But they took that to mean, our leaders who taught us about all this in the late 1990s, they took this to mean that you could do the same thing with people in chronic pain, that you could give them opioids and that addiction would be extremely rare. This Porter and Schick article was cited over and over again. Dr. Portnoy was one of our leaders among many others who taught us these things. I think that the intention here was not bad. It was the thought that maybe you could comfort people in chronic pain just like they Foley and Portenoy learned to do in patients with cancer pain. And so this was Dr. Portnoy's early case series. And the funny thing about this case series, that I asked him about this, none of the patients that he had in his practice were disabled. None of them were on workers' comp. None of them had back pain. They were mostly post-herpetic neuralgia, things that neurologists would typically see and treat in a tertiary care practice. But the one thing I wanted to point out here that's really important is of the 38 patients that he reported, only 4 were on over 40 milligrams morphine equivalents a day. And I have to tell you that by 2006 in this state, just in our public programs and Medicaid and workers' comp, we had 10,000 patients, 10,000 Washington citizens just in the public programs that were already on over 100 milligrams a day. So this is a far cry from what I think Portnoy had in mind. And what I would ask you in your practices is, how many people in your practice are on high doses of opioids? How many have been on opioids for longer than 3 months? How many are on combinations of opioids and benzodiazepines? Because that's even more deadly than just high-dose opioids. And the problem is that the folks that got really excited about maybe using opioids for chronic pain, they were teaching things back in the late 1990s that were not true. And these are the kinds of teachings that this was based on no evidence at all, that there's no ceiling on dose, that the way to treat tolerance is to keep increasing the dose. And these teachings ended up in more than 20 states in their regulations at their medical boards. So in our state, for example, the language was no disciplinary action will be taken against a practitioner based solely on the quantity or frequency of opioids prescribed. These were intended to be safe havens for doctors that were hesitant to use opioids previously from many years of teaching. But the problem is that none of these teachings were based on any real evidence. And so this has led to what I have taken to call the worst man-made epidemic in modern medical history, made by man, made by teachers, made by drug companies, and many others. Over 175,000 deaths, about 1 death every 2 minutes. Many more hundreds of thousands of overdose admissions to emergency departments and hospitals, and millions addicted or so severely dependent that they will never come off of opioids again. It probably doesn't take longer than about 30 days of being on opioids to possibly never come off of opioids again. You can develop enough dependence in 30 days that it would be somewhat difficult to stop opioids at that point. If you're on opioids for 30 days, you're still 50% likely to be on opioids 3 years later, just after 30 days of use. This Degenhardt, yeah.
How does that compare with former drug addicts that are put on opioids?
Well, if you have a history of addiction or substance abuse, that's going to be worse. I mean, everything is worse in folks. Generally, if somebody has active substance abuse now, you wouldn't use opioids unless it was, an urgent, terrible pain problem. Let me tell you what. Let me go through this because I started a little late, and I'm happy to come back to any questions you might have. This is a paper that just was published recently in Lancet Psychiatry. Another false teaching was that less than 1% of people develop opioid use disorder or addiction. The fact is it's more like 20 or 30% of actually true addiction. And the problem is that most people in practice who have chronic pain who are getting opioids from their doctor, they don't meet the usual case definition of aberrant behavior because they don't need to. All they have to do is to come in and tell the doctor, well, my pain is an 8 this week and it was a 7 last week, and the doctor might give them more opioids, and they don't have to crave, they don't have to flush it down the toilet if their doctor is giving them that much drug. And I'm not sure this is going to work here. I don't think it is. Okay, so that was a video which I can share with you of Russell Portnoy, who was interviewed a couple years ago, and it was put online on the website Physicians for Responsible Opioid Prescribing. And he said that if he knew then what he knows now, he wouldn't have said all those things. He tried to get the video taken down after that, and I guess my main problem right now is where are these guys that taught us to do all this stuff? Why aren't they out there now teaching us to kind of try to help reverse this thing or do something different with our patients, but they're mostly not out there. Jane Valentine, who wrote the first main article in the New England Journal in 2003, she's out there, but she's one of very few pain leaders in our country who have been doing that. You can also say that, I mentioned this earlier, that 100% of patients on opioids chronically for at least 3 months are dependent, which means that they will have withdrawal effects if they try to come off the medication. Jane Valentine calls the large swath of people who are dependent on opioids now or disabled the lost generation. And we're now fighting about, how many of these people can get medication-assisted treatment, how many can be tapered, who can be actually treated effectively or not treated effectively for addiction, and we don't know the answers to those questions. So what do you have on the other hand after all this damage and carnage from opioids? Not much. The evidence as to whether opioids actually help long-term is very slim. And in a systematic review of all of the evidence done by the Agency for Healthcare Research and Quality and published in the Annals of Internal Medicine last year, the conclusion was that there is insufficient data on long-term effectiveness to reach any conclusion, but very strong evidence supporting a dose-dependent risk for serious harm. This is a slide that shows the 4 major studies that looked at, these are large epidemiological studies that looked at the relationship between dose and either overdose admission or overdose death. And you can see here that at just 100 milligrams, remember we had 10,000 people in the state in 2006 that were on at least 100 milligrams, that the risk of a serious overdose event is up to 9-fold compared to less than 20 milligrams a day. And the risk between 50 and 99 milligrams is up to 4-fold higher compared to less than 20 milligrams. Average people in systems like group health cooperative, people in chronic pain who are getting average doses are taking around 40 to 45 milligrams a day. So these doses are associated with dramatically increased risks, which is why I asked you earlier, do you have patients in your practice that are on these high doses? We also published a paper in 2008. We did a large prospective study of almost 2,000 injured workers with low back pain and some time loss. And we found that if these workers got just 7 days of an opioid or 2 prescriptions in the first 6 weeks after the low back injury, they were twice as likely to still be disabled 1 year later, adjusting for their self-reported pain and dysfunction and severity of the injury. So and there are about 5 or 6 other studies now that aren't as strong as this one that are more cross-sectional and retrospective, but they all show the same thing, that I believe that an injured worker getting an opioid for a non-specific low backache, opioids can actually help contribute to the initiation and perpetuation of disability. I mentioned earlier that there's this problem with defining dependence and substance use disorder. And again, these folks don't have procurement behaviors because they don't need to when they're coming to get their drug from their doctor. So I was asked to write a position paper for the American Academy of Neurology, and this was vetted by hundreds of people, including the editors of the journal and hundreds of network people, and by 3 committees in the Academy, including the Board of Directors, Practice Committee, and this Patient Safety Subcommittee. And the conclusion of that paper was that there's a terrible imbalance between what is known about effectiveness on the left side and what is known, again, about these risk-dependent and dose-dependent harms, which is this huge weight on the right side. And the conclusion of that paper, and also in Washington State in our guidelines, is that opioids should generally not be used routinely for the treatment of routine musculoskeletal conditions, headaches, or fibromyalgia. And I don't really have time to go into the detail on that, but the evidence on effectiveness for these conditions is very slim. So just some examples of why you might not want to prescribe for chronic low back pain, aside from the fact that the evidence is slim, that alternative treatments, particularly things like cognitive behavioral therapy and graded exercise that take a psychosocial or psychophysical approach, have a stronger evidence base. Opioids generally are deactivating and not activating if your goal is to make the person more functional. Reduced prescribing for nonspecific back pain would significantly reduce overall prescribing and availability, and thus have a public health benefit from less use of the drugs, from kids taking it out of the medicine cabinet, etc. And then eliminating prescribing for common conditions that have failed would be a step towards identifying cases that might derive benefit. And I think most people right now think that only about 1 in 7 patients on chronic opioids might be getting along okay enough and not be in harm's way so much, but it's about 1 in 7. But nobody knows how to pick those people. So after I reported the initial deaths from Washington State in 2005, the agency medical directors group, which I led, which was all the agencies in Washington, got together with 15 or 20 of the highest level clinical and academic pain experts in Washington State, and we came up with the nation's first opioid guideline that actually included a threshold, a dosing threshold. Remember, the teaching was there's no ceiling on dose. So when we came out with this 120, it was a best guess. It was before those 4 studies on that graph I showed you earlier came out, and we didn't really have a clear-cut idea of where the risk would dramatically go up. But actually, 120 is a pretty good guess. It was kind of at the upper end of that start of a dramatically increased risk from these doses. And all we said at that time was, if you have a patient and their dose has been creeping up and you get to 120, stop doing that. Get a pain consultation, and especially if the patient has not really improved. And the key is, are people actually getting clinically meaningful improvement from anything you're doing, but especially from something like opioids, which can be deadly? We also included some best practices that everybody agrees on these best practices. These are in every single guideline. If you're going to use opioids chronically, you should have a treatment agreement. You should screen for past and current substance abuse. You should occasionally do random urine drug screening. Should not use concomitant sedatives and hypnotics. Should track pain and function using a 2 or 3 question questionnaire, which are present on our website. You can just print them out and put them in your chart every time they come in, and use our opioid dosing calculator to plug in using the state prescription monitoring program. You can look up where your patients are getting all of their controlled substances from, and you can calculate exactly how much opioid they're taking. So if you have somebody on opioids, you should be tracking at every single prescribing visit their dose and the 2 or 3 question questionnaire on how they're doing in terms of pain and pain interference with function. So from this initial effort in 2007, we rolled the guideline out. We got sued. We got a nasty letter from Purdue Pharma saying, how could you blame doctors for this? It's got to be misused by the patient. And we actually ended up having a pretty dramatic decline in the workers' comp system in terms of opioid doses and the proportion of workers who were on 120, which is the little red bar. And we had a decline in the average daily dose from 140 milligrams a day in workers' comp to about 105 milligrams a day in workers' comp. And actually, we had about a 50% decline in deaths in the workers' comp system, and this has persisted. So we've had a ongoing at least 50% decline. This is not a lot of deaths. This is, at its peak, it was around 30 a year or so. But we've also, since publishing that first guideline, had a pretty dramatic and sustained decline in the state overall in unintentional deaths from opioids, from about 512 deaths in 2008 to 319 deaths in 2014, about a 37% decline in deaths. The problem is that there are people, especially young people, especially kids 18 to 25, that are moving over to heroin. And the decline in prescription opioid deaths in the 35 to 55 year age group is being offset by dramatically increasing deaths from heroin in the 18 to 25-year-old age group. A recent article in the New England Journal of Medicine a couple weeks ago basically talked about how there is no clear-cut relationship between states like ours trying to do better and clamp down a little bit on unnecessary opiate use and this increase in heroin death rate. This is a study that was recently published that looked back in time to the 60s at heroin epidemic back then, and saw that people that started heroin back then almost always started with heroin, whereas most people who start heroin now start on prescription opioids. So that it's the prescription opioid epidemic which is actually feeding either directly or indirectly most of the increase in heroin use these days. But again, that is largely in that younger age group. And this is the Compton et al. Article in the New England Journal that was just published that made these arguments. So we recently updated our guidelines in 2010, and then we updated them again just this past June. The guidelines, the Washington State opioid guidelines, are now much more comprehensive. They include definitions of clinically meaningful improvement in pain and function. 30% improvement in pain and function is what you have to have in our state to recommend that you keep getting opioids. If you're not better than that, you probably don't want to take the risk with those drugs. There are a lot of other aspects of the guidelines that were added, such as perioperative pain use. You know, a lot of people come in the hospital for elective surgery, and they're on high doses of opioids. It's very hard to treat those patients. And in any case, they should be back on the dose they were on when they came in the hospital no later than 6 weeks after they leave the hospital. And if you came in the hospital for surgery and you weren't on opioids, you don't want to start becoming dependent on opioids after surgery. So they should be off of all opioids in most cases by 6 weeks after surgery. We also included a case definition for when to discontinue opioids and how to discontinue opioids with clear-cut algorithms for tapering, which have not been published in other guidelines. We've done two primary care surveys in Washington of 600 to 800 primary care prescribers, and we wanted to know both after our first guideline and more recently, what do doctors need? What do they think about these thresholds? Because there's been a lot of fighting over these thresholds, and 85% of the primary care docs said that the 120 milligram threshold in our guideline was either just about right or too high. That the prescribers feel like they need these tools in their offices to help deal with some of the more difficult patients. And the other thing is that the doctors are in systems that have more support in their systems, such as guidelines built into the EMR or easy access to pain management. Those doctors are much more comfortable taking care of pain patients and even in using opioids. I'm not going to go through these emerging recommendations, but the main thing in our new guideline is you don't even really want to get started on opioids with acute pain inappropriately. So, for example, if somebody comes in with acute low back pain, you probably should use other treatments other than opioids. And if you actually end up using an opioid, it probably shouldn't be for more than a few days. If you end up using it for as much as 6 weeks, then you should determine if the patient has had clinically meaningful improvement in pain and function. And if you haven't, with that episode of acute pain, you should not keep using the opioids. You should be checking the state prescription drug monitoring program. And I'm not going to ask how many people in this room actually have registered and used the state PDMP, but I can tell you it is an extremely useful tool if you're going to use opioids. So the impact of all this is that the whole point of not using opioids inappropriately in the acute pain phase is to try to prevent the next cohort of our citizens becoming so dependent and addicted that they're never going to get off of opioids. So this is a curve that shows that from these efforts in the last several years, we have had a dramatic decline in the incidence of chronic opioid use in workers' compensation patients. Among our workers who got at least one prescription for an opioid in 2007, about 7.5% went on to chronic opioid use, and now it's about 1% that went on to chronic opioid use. There are a number of states besides ours now that have introduced dosing thresholds, and Connecticut has 90, Ohio has 80, Indiana has 60, and the new Centers for Disease Control guidelines, which are probably will be coming out very shortly, and I haven't seen the final, are probably going to have two thresholds. One with about 90 milligram threshold that you shouldn't go above, kind of like a red flag, and 50 or 60 that in patients with certain comorbidities like past history of substance abuse or alcohol use or whatever, you probably shouldn't go above 50 or 60 in those patients. Don't use benzodiazepines concomitantly. The other thing that we've been working on lately is if you look at this data from the National Institute of Drug Abuse, you can see that most of the prescriptions for opioids are written by dentists in kids that are 20 and less. That most of the prescriptions in people that are 20 or 25 and older are written by primary care. But the largest doses are being written by specialty pain people and rehabilitation pain people. But so we wanted to focus on this, the dental thing, because we think that a lot of kids are going to get their wisdom teeth removed, and they're being given 15 or 30 days of oxycodone when they might need 2 pills. And then they put the rest of it in the medicine cabinet, or they can sell the oxycodone for $1 to $2 a milligram at their school or on the street. This was a study that was just published in Pediatrics that looked at what happened to kids that got a prescription for an opioid in high school. There was a 33% increased incidence in those same kids just a couple years later, between the ages of 18 and 23, of misuse of opioids, non-medical use of opioids. So this, again, to us is kind of like a link here that reducing inappropriate acute use, especially in this population, might have a big impact on reducing the move over to heroin and the increase in heroin deaths. The other thing we discovered from our studies, and this is a new study by La Rochelle, is that most people, the majority of people who come to the ED or the hospital with an opioid overdose, leave the hospital and go back on the same drugs. Just to continue the same medication at the same doses. And those same people, of course, overdose again or die in some cases. So we see this as a pretty big opportunity to look at the possibility of reportability of these events. There's a million things that are reported to the Department of Health. This is not one of them, but we're pushing the Department of Health to make this a reportable event from hospitals so we can do something to help these patients. I give a lot of talks all over the place and on this stuff, and I tell different states and other venues, these are the concrete policy steps to take. Number one, the reason we were successful here in this state is that our government, our governor and our legislature expected us all to work together. In most places, half the deaths are in Medicaid. In most places, the Medicaid agencies don't even talk to the other agencies. And in most places, Medicaid doesn't even know how many deaths they have or how many people they have on high doses. So it took a lot of collaboration in this state, and we published a paper in the American Journal of Public Health talking about how that collaboration was done. Secondly, to reverse some permissive laws that I mentioned earlier, that more than 20 states you are using these so-called model laws that gave doctors safe haven, but with things like, no doctor shall be sanctioned for any amount written. A medical board can't do anything about that doctor if that kind of language is in the state law, even if they're have the worst of the worst sort of pill mills. Set dosing and best practice guidelines. They don't necessarily need to be in rule. Establish metrics for tracking progress and track your patients and their pain and their function. Implement an effective prescription monitoring program. Right now, across the country, only about 28% of prescribers are registered for these PDMPs, and probably many fewer than that actually regularly use them. I think this is a big deal to me, and this is where I do some work, is to encourage or incentivize the use of alternatives to opioids, such as activity coaching, graded exercise, because a lot of insurance companies don't pay for this stuff. So it's hard as a government or whatever to tell doctors to stop using opioids when we don't have a lot of other tools for them to use. And so I really am a big believer in paying for these alternatives to opioids, which have very strong evidence bases. So, for example, cognitive behavioral therapy has been shown in 10 meta-analyses for 10 completely different pain conditions to be highly effective. including last year in the American Journal of Gastroenterology, highly effective in inflammatory bowel disease, pain. You may have heard that the Nobel laureate in economics at Princeton, Angus Deaton, and his wife, Case, recently published this paper that got a lot of press in the proceedings of the National Academy of Sciences, that while the mortality rates in most age groups and in from most diseases is going down in our country, I just recently saw today that the dementia rates have gone down pretty significantly in the last 4 decades. But in the 45 to 54-year-old age group, especially in the less educated whites, there's a dramatically increased mortality rate, the likes of which people have never seen before. And guess what? A lot of it is from drug poisoning and opioid poisoning, because that 175,000 deaths that I showed you earlier since 1999, that wasn't happening before. So that, if you add up all of those deaths and look at these mortality rates, you're going to get a hugely increased mortality rate in these middle-aged whites, many of whom are, in fact, injured workers. I mentioned the CDC guidelines, which were coming out. I was on their advisory committee, and then there was a huge kerfuffle because some of the usual players, drug companies, surrogates, and other pain leaders were complaining about the guidelines. They never saw a dose they didn't like, so having these dose thresholds in there was not, they didn't like that. But anyway, so they had to re-release them in the Federal Register, take public comment, but I understand they will be coming out soon, and they're in press at a major journal right now. So I suspect that once the CDC guidelines come out, there's 12 great recommendations that this will help guide other states. They don't have to go through what we went through to develop our own state guidelines. And that's it. That's a kind of a quick, short story, but you can tell I'm a little passionate about this. I'm happy to take questions.
We're going to minimize your screen so that we can get questions that could be typed in from other sites, Gary, that are listening to you. If I can preemptively just make a short comment. I really, I was able to hear you when I left because I'm up there in the booth answering that. Okay, but the thing that I think is terrific about what you're doing is that it's a balanced view. You're not, you're not shrill on the topic of suppressing opiate use. You're in the middle. You're trying to have it done in a way that's intelligent and as risk-free as it's humanly possible to achieve. And I think what happens sometimes is that topics like this become passionately discussed and people get whipsawed one direction and the other direction. So finding this middle vein of sensibility really is absolutely crucial. I have one concrete question. In one of your very first slides, you told us about people dying, the 175,000 per year that are dying in this country. I remember 1 every 5 minutes or something.
2 minutes.
I presume that a portion of that population of opiate deaths are people that are shooting up heroin and other kinds of opiate substance, or is that just people on?
The 175,000 is just from prescribed opioids, either directly in the patient getting it from their doctor or by diversion once it's been prescribed to somebody else.
What's the number like when you include opiate deaths from drug users that are using heroin?
Well, so I showed you the heroin numbers that were going up, and so the heroin numbers are probably about a third of the increase in heroin deaths. That's about a third of the overall prescription opioid deaths, but it was very low, 6 or 7 years ago. It's going up very quickly, but again in that younger age group, which is horrifying.
So one of the pieces of this, when I think about your reference to dentists and wisdom teeth, is I think it quite commonly happens that in that instance, too many are prescribed and the prescription allows a refill. And it would be very simple if there were guidelines or education of people who are treating those kinds of known acute pains to limit the number that are prescribed and not allow for a refill. Just those two simple things, I think, would make a big difference.
Right. So I didn't show a slide on this, but there's a thing called the BRE Collaborative in the state. It's a statutory committee that's a public and private collaborative of all the health sectors, the hospitals, the commercial payers, the public payers, WISMA, et cetera. And we've formed they've adopted our guideline. They've endorsed our guideline. And now there's a work group working to implement the guideline in sectors that have not been working on it that much, like commercial payers and like dentists. So one of the 5 goals of the BRE Collaborative Opioid Work Group is to engage the dental community in coming up with exactly that kind of a recommendation to, not prescribe more than 2 or 3 days of a short-acting opiate after these procedures. And I think, it seems crazy, but I think it would have a tremendous impact on this heroin thing. But I agree with you completely. Yeah. But on the surface, you think, well, how hard could that be, right? But it hasn't been easy to engage that community. It turns out that Michael von Korff, who is a partner in crime on a lot of this data, his wife is the associate dean of the dental school, and Linda La Recherche, and we're gonna meet soon, and we're gonna meet with the dental commission and some of the leaders in the dental world in the state to see what we can do, because I'm pretty sure that not much attention is being paid to this one issue.
Gary, I'm pretty sure you can't call for refills for standard opiate drugs.
You can't call for. You can only call for refills for, I think, for Schedule III drugs.
Yeah, I mean,
But
I think some of this is already.
Right, hydrocodone was upscheduled to Schedule II. So
When you write a prescription, can you say for like hydrocodone, can you say refill twice?
no,
You can't.
no.
You cannot.
It's new.
You can't do it. No.
You can't. You can do it for schedules like codeine and codeine products, but not any more hydrocodone.
No, that's a good thing.
Yeah.
Am I also correct that in the state, the pharmacies have a system now where they're able to monitor patients who are getting prescriptions at different pharmacies for the same thing?
Yeah. So there's 2 things. One is the prescription drug monitoring program, which I mentioned, which every time a drug is, whenever you get a drug at a pharmacy, it's automatically entered, and all of that data for controlled substances is now fed into the state prescription drug monitoring program. And if you sign up as a doc, and you can do it, or you can sign up your MA as a delegate, or other people in your office. You don't have to do it all yourself. You can see where your patient is getting all of their controlled substances from. Maybe they're getting opioids from 3 different docs, or maybe they're getting some benzodiazepines you didn't know about. So I would, again, strongly recommend you use that. Also, in the state, the emergency departments have what's called the Emergency Department Information Exchange, where they can hook up with each other for the frequent flyers that are going to the EDs like 10 times a month, and they're able to control that a little bit. And now the prescription drug monitoring program has hooked into the ED in the emergency department. So when a patient comes in who's on opioids, the doc in the ED can just open it up and it's right there. Also, the PDMP program is trying to make it easier for docs to sign up by allowing you to do it through the One Health port, which is another entry point for utilization review and other things in the state. But there's not any interoperability between the PDMP and the VA, and there's no I think they're working on that, and there's no interoperability between that and the military. I mean, the military bases are awash in opioids from the returning wounded warriors and all these folks. And a lot of that is in folks that have had musculoskeletal injuries, not war wounds. We had a death in Tacoma about 4 years ago. Two folks from Madigan were getting stuff. It was in their medicine cabinet. Their kid went in and took one strong pill and died that night.
So, would opting out of the DEA registration for certain specialties would help?
I'm sorry, I couldn't hear what you said.
So, sort of certain specialties, like neurology, for example, not doing the DEA, not being DEA. Certain specialties, do all specialties need to have the ability to prescribe opioids? I mean, for neurology, our main bulk things are headache and back pain, and in those two situations, we shouldn't really prescribe opioids. I mean, does neurologists in general, they're not applying
There were hardly any neurologists. You know, I had a big debate with.
I mean, I know some attendings don't have DEA for opioids. Just we don't prescribe it. We cannot prescribe it.
I think except for severe neuropathy, and maybe some collagen diseases that are very painful, or maybe in some instances even of MS or spinal cord injuries. I mean, there are some.
Tumor, I mean.
Yeah, any cancer, anything like of that ilk, of course. But I think that for most non-specific musculoskeletal problems or headaches or fibromyalgia, not using them at all is probably the best thing to do. Or if you have to use them, just use very low doses and use them intermittently. But there are overdoses, many overdoses in people that are using them intermittently and on low doses.
Can you talk a little bit more about the spillover effect of heroin and what our state is thinking about it, what our leaders are thinking about it? Because it sounds like our patients are telling us that we're not treating their pain, we're trying to find other ways to treat it.
I'm not sure that's what it says. You know, if opioids don't really help the pain, even though you're on high doses, then where are you at? You're only at risk. You know, if you're on 300 milligrams a day and your risk of having an overdose event is sky high, but most of these people don't report actually feeling a lot better in terms of their pain and function. And epidemiological studies have seen the same thing. There was a study by Erickson in Denmark. I looked at thousands of people in chronic pain, and they talked to people in chronic pain who were on opioids and those that weren't on opioids, and the people that weren't on opioids reported much better quality of life. I don't think that is true, but to me the way to get at the heroin issue is first of all to understand the demographic difference, that the increase in heroin deaths is mostly in that younger age group. Okay, so why is that happening in kids? What's happening probably because of overprescription in kids and or diversion from their parents' prescriptions that are overprescribed and stuff is left over. And, you know, I think it's a common popular, opioids have become very popular among kids on the street. Yeah, it makes you feel euphoric for a while.
So you think that this increase in mortality from heroin in young kids is more that it's more recreational?
No, I think that they have become dependent on opioids, either because they were prescribed opioids or because for a sports injury or a dental procedure, and then they liked how it felt, so they went and got some more, and then by the time they were 18 or 19 or 20, they're misusing off the street, not for prescriptions. So yeah, it's the fact that the vast majority of people that are new initiates on heroin started out on prescription opioids. And whether that was prescribed or diverted, that's in some cases it is diverted. But it all starts with the oversupply of prescribed opioids, of unused opioid or too much opioid. Yeah.
Are all the prescription opioids equivalent in terms of the risk, or are there things which are much higher risk than others?
The question is whether all the opioids are equivalent in risk, and the answer is probably the long-acting opioids are more dangerous. And that's why the recommendation in acute pain is if you have to use opioids, use short-acting opioids, but not more than for a few days. So yeah, I mean, long-acting, is and methadone is well known to have, it's got really long half-life. It ends up hanging out in the body for a long time, and that has it's particularly dangerous to switch over to methadone from something else. You have a question about?
Yes, so I've inherited patients on agents, and it's a very uncomfortable scenario. And there's so many people not prescribing, people kind of hanging out there. So, do you have any strategies for approaching people or decreasing their medication? I inherited somebody who's on 300 milligrams day of sustained release of morphine, which makes me extremely uncomfortable. She's been that way for years, and there have never been any issues.
So I guess the first thing I would do is I'd want to talk to their family with them in the room to see if they're functioning as well as they say they are. I think that a lot of these folks, the families know that they're addicts, but they're not going to tell you anything untoward when they come in because they're so fearful of coming off. They're literally, either they've experienced the withdrawal or they're extremely fearful of just being in terrible pain. The fact is, there are studies that show that when you come into a pain clinic, like the Mayo Clinic did a study like this, they took people off of opioids or they didn't, and the people that were taken off did much better in the pain clinic than the ones who weren't taken off. People do not do well on chronic opioids. So our new guideline has a whole section on tapering and a case definition of when you should taper and how to taper. So, it's about 10% a week or less, with or without buprenorphine, with or without cognitive behavioral therapy. There are great people here at the university that are total experts in this stuff, and at the pain center. Andy Saxon at the VA, Rick Reese. There's just a whole host of people here. We're awash in pain experts here at the UW. Really great people. So I do think it's worth checking in with your patients on high doses and to talk to their families. It is a slog. I'm not going to lie to you that they just had a randomized trial funding thing here at the university, and they had a really hard time recruiting people for the randomized trial to taper, as you can imagine.
Gary?
But everybody agrees that what you're really treating is the stress. You're not effectively treating pain.
Yeah, Gary, quick question for you about pain pumps. When do you think it's appropriate, and do you think there really is utility in delivering narcotics that way and successfully controlling pain?
Well, again, I would differentiate kind of the malignancies from all this other stuff. I don't think, in this state, our state health technology program determined that the risk was too great and the evidence of efficacy was too low to cover pain pumps. So in our public programs, pain pumps aren't covered. Medtronic themselves published a study from one of their own people that showed the death rate in pain pumps. It's pretty high. It's like 3 or 4%. So so if they're not helping that much, one thing for sure, they were introduced to try to help people get off of oral opioids, but patients that we had at O&I who had a pain pump, they weren't doing well. They did not reduce their other opioids. Has that been your experience? Have you been able to reduce?
I just haven't seen much success with pain pumps, getting them off of oral, even if they're getting much benefit. That's true also for other things like spinal cord stimulators. I'm just not convinced those things will help.
I mean, if opioids and all the data don't show great effectiveness, I don't think it really matters how you deliver it, right? Except that way is $100,000 way, and this way is a little bit less. Those things like the spinal cord stimulators over 5 years, $125,000,
I just find that,
and they don't help either.
And the pain docs are stuck; they have nowhere other direction to go. The patient doesn't respond to anything else, and that's all they can throw out there.
Well, I think we need to do a lot more dealing with the psychosocial barriers to recovery, and we've done so little of that, honestly. And a lot more of that stuff needs to be done. What we're thinking about at O&I is trying to develop the concept of a pain home in a community to get the resources in communities to help docs deal with these difficult patients. Have like a team in the community. So, for example, there's a whole thing going on in, I think it's Vermont, where they have regional medication-assisted treatment centers with a doc specialist expert and a care coordinator helping the docs in the community taper or treat dependence or addiction. And I think that's really what we need. We need more comprehensive multimodal care and more tools to help deal with these, these patients are hurting.
Here, I think there's a remote question from Dr. Gosby.
Okay, there's a question on, is there a pediatric milligram per kilogram per day recommended maximum dose and time limit? Not that I've seen, but if you look in our new guideline online, there is a new section written by one of our stars here at Children's Hospital on opioid use in kids. So I'd recommend you take a look at that. There are special sections on special populations, including pregnancy and kids. Yeah.
Speaking of resources, do you have any suggestions on availability of CBT? I haven't tried to get it in this context, but in other contexts, I just find it very hard to have that funded for patients. Cognitive behavioral therapy.
Well, the thing you have to remember, so the question is, is it easy to find cognitive behavioral therapy? And that's why I'm making the point that I'm spending a lot of time trying to figure out how we can incentivize. And actually, I have challenged Medicaid, for example. You guys have to pay for this, and so they're thinking about it. And I'm not going to be happy until they do pay for it, until they get their managed care plans to cover it in their contracts. So I agree with you completely, but you have to remember that it's not always rocket science to deliver that stuff. Like we're doing a lot of what we call activity coaching, which was developed by a psychologist in Canada. It's delivered by occupational therapists. It is a form of cognitive behavioral therapy because it directly addresses psychosocial barriers to recovery like fear avoidance, catastrophizing, feelings of injustice, all the things that people feel that lead them down a kind of a bad path. So I think that one thing is that it doesn't have to be delivered by a PhD psychologist. It can be delivered, and so this pain home that we're working on in the community, we're looking at Jürgen Unitzer, the chairman of psychiatry here, has developed this method over many years of collaborative care in the community with the collaborative care people being able to actually deliver brief interventions like cognitive behavioral therapy, mindfulness-based stress management, dealing with sleep hygiene. These are all the bane of most people in practice, and these are the things that are not properly addressed. So I think that while there may not be a lot of sort of what you might think of in the old days as cognitive behavioral therapy, there are many new treatments taking on that have elements of cognitive behavioral therapy, and I'm really excited about this because they can be delivered by a lot of different kinds of folks. They're cheap. It can be done telephonically. So we're investing in that big time at LNI.
Gary, it seems to me like it's a two-stage process to get where we want to be. One might be to intervene right now to curb this huge rate of death, and then to develop strategies for people that are addicted and are threatened and fearful, et cetera, et cetera. They don't have a lot of choices right now. But the first step, the intervention step, I mean, why don't they just put all of these pill factories out of business? I just cannot comprehend. And you read about it, so clearly some of them are being arrested and driven out of that marketplace. Why isn't it happening across the board?
Well, the pill mills, even in Florida where they were at their worst, and people were flying down there and flying pills out, to 5 states or 6 states. But even when they're shut down, that had a big impact on the deaths in Florida. But that still left 80% of the deaths that weren't affected because most of the prescriptions are not being given by pill mills. Most are being given by just, primary care people all over the place because of the teachings that occurred in the late 1990s. Comfort your patients, no ceiling on dose. And so, a lot of people have had the experience that they've inherited, like you have, patients on 200 or 300 or 400 milligrams a day. And if you inherit a patient like that, it's tough. You feel for them, and you want to do everything you can. I got to tell you, the reason I left practice was I was inheriting these patients, this was back, a long time ago, who had failed back surgery syndrome. What a great term, right? You do a lumbar fusion and you develop arachnoiditis and horrible, radiculopathy from failed back surgery. And once that happens, you really can't do anything about it. But they keep operating on them for whatever reason. And, that was one of the reasons I left to go to try to see how can you prevent this stuff from happening. So we're working on preventing. The state just decided, by the way, that we should not cover lumbar fusion for nonspecific low back pain. That was just January 15th. So that's the public agencies. So starting pretty soon, L&I and Medicaid and the other agencies are not going to be paying for as many lumbar fusions, and hopefully we'll have people better off from not having these invasive things done to them.
We can fix that. Unfortunately, the unscrupulous can fix that with an eraser. It's not a non-specific back pain, it's a lumbar radiculopathy. So I don't, much as I hate to say it, I don't have high hopes for that step.
Well, I'll come back in a couple of years and,
Prescribing more opioids.
yeah. Anyway, thank you for having me, and I appreciate it.